All right, we have a very packed agenda for today, so I'm going to go ahead and dive in. We're going to start just with some welcome and housekeeping before we go in to the rest of our conversation today. Welcome, everybody. I'm Caitlin. I'm our Assistant Director for Medical Respite here with the National Healthcare for the Homeless Council, and this is our funding virtual symposium, long awaited, something that we've been wanting to do for a long time. So very grateful to be together today. First of all, this is from the National Healthcare for the Homeless Council. Many of you are likely not new to us, but just in case that you are, we're the national organization working at the nexus of homelessness and healthcare. And our mission here is on the slide, grounded in human rights and social justice. Our mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. And these things certainly do not exist without each other. Many of you are familiar with NIMARC, or the National Institute for Medical Respite Care. This is our special program of the Council, whose primary work is to focus on expanding and supporting medical respite or recuperative care programs across the country. And just a quick note, recuperative care and medical respite care mean the same thing. You might hear those terms used interchangeably today, but really we are talking about the same programs and same services here. And NIMARC exists to support best practices, deliver consulting, and disseminate state-of-the-knowledge field around medical respite, including funding. So again, thankful that you all are part of our community here together. It is one of our practices here at the National Healthcare for the Homeless Council to begin all of our events with a land and labor acknowledgement. Although we are here together in a virtual space, we are all interconnected by the land beneath us. Most of our communities reside on unceded ancestral lands or were acquired by unhonored treaties. We acknowledge the people of these lands, past and present, and honor with gratitude the land itself and its people. We also honor the brilliance and humanity of all immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented peoples whose labor remains hidden in the shadows, but still remains a part of contributes to the well-being of our collective community. By recognizing the land that was taken from first Americans and the forced labor that was provided by enslaved Africans and Black and Brown people, we strive to take steps towards creating a more equitable and just world for all of us. And Chris has shared in the chat, if you are interested in reading the labor acknowledgement where this was drawn from, or learning more about your native lands, you can click those links below. So we have a couple of intentions that we also like to include when we are in our virtual learning environments together. First, we want to make sure that whenever we're speaking that we are being inclusive. We want to note that everyone here is welcome, and we want to show that through our actions and the language that we use. When we're talking about other folks, we want to make sure that we're using neutral, gender neutral and person first language, avoid stigmatizing language when we talk about things such as disability, mental health, substance use, and other conditions. Additional links will be shared if you're interested in learning more about inclusive language. We also want to be engaged. This is a long day today. I want to acknowledge this is a 4-hour virtual symposium, but we are really hoping that in the way that this has been structured today, that you will have an opportunity to sit and listen and learn, but also to engage with each other. We're going to have breakout rooms, and the breakout times are going to be most useful if you enter ready to ask questions and share your experiences. And we'll talk a little bit more about that in a minute. And then finally, as we are engaging with each other, we just want to make sure to be mindful about the space that we are taking and the space that we are making for others. We want to make sure that everyone's unique experiences and perspectives are heard and that everyone has an opportunity to participate. So with that being said, let's really dive into funding. So the visual that's up here really reflects many of the primary funding sources for medical respite programs. The goal of this symposium today was to learn about each of these mechanisms while thinking about how they can be braided together to support program sustainability. We've had a lot of conversations and resources that have focused on maybe one or two of these specific areas. And inevitably, when we're doing that, the other ones come up. So hopefully by combining all of these conversations today, that we'll be able to really learn and think about how we can use these different mechanisms together. There will be breakout sessions. So the listed funding sources are going to be the structure of our conversation today. There are going to be breakout sessions integrated for several of the topics here. The goal of the breakouts is to be able to ask questions of the facilitators who are experts in the field, as well as others who are participating in the group, to be able to share your experiences, recommendations, and ultimately learn from each other. So these breakouts are going to be most productive if you're ready to participate. You'll have the option to select your breakout that most applies to you and your program for each topic. We'll give additional instructions again when the time comes to be able to move into those breakouts. I'll also note that this is being recorded and will be posted and available for watching later in case you need to step out and come back in. The slides presented today will also be posted along with contact information for presenters and additional related resources. So you can really just sit and engage. All of this will be available for you later. And finally, with a deep breath, I want to take a moment to recognize that the landscape around several of these funding sources has drastically changed within the last 2 weeks and perhaps even within the last 24 hours. We're going to do our best with the conversations, noting that all of this is going to continue to evolve. If you're interested in what we are doing from an advocacy perspective, as we noted, advocacy is a huge part of our work, please consider signing up to receive the Council's Mobilizer email or join our policy committee. We're also going to be dedicating time at our February 26th all-member meeting for policy updates and what this means for medical respite care. Links for those, if you want to sign up for the Mobilizer or to join the policy committee or to join the all-member meeting, are going to be posted in the chat. So there's a heavy asterisk kind of overlaying all of these different conversations today. We know that we're going to do our best with all of it and hopefully come in community together about what these changes might mean for programs. So here's our agenda for today. We are going to dive into hospital funding first. There's going to be 2 presenters, and then we're going to have an opportunity to go into breakout group discussions. Following our hospital conversation, we are going to talk about Medicaid, and there's going to be several breakout group options for Medicaid as well. After kind of diving into those very heavy, high topics, we're going to have an opportunity for a break, kind of some resetting. And then our conversations this afternoon will focus on grant funding and fundraising, health center funding, HUD funding. And then at the end, we're going to weave it all together, braid it all together with a panel who's going to talk about how they make these different funding mechanisms work for their specific programs. So with that, I'm really excited to introduce our speakers for today. We have Monica Ray from Cottage Health and Laurel Nelson from the Center for Respite Care in Cincinnati, who are going to present from their 2 different perspectives around funding and hospital systems. So I'm going to invite Monica to go ahead and pull up your presentation.
Great. Thanks so much, Caitlin. Hi, everybody. I'm Monica Ray. I'm the Population Health Strategic Development Manager at Cottage Health. We lead a 10-bed recuperative care program on the Central Coast of California, and I'm here to share as a hospital partnering on this program. I'll cover background on our program, some of our evaluation outcomes, and what's important to us as a hospital partner. To begin, a little background on our program, we're Cottage Health is a 3-hospital healthcare system located on the Central Coast in Santa Barbara County, California, where we have Santa Barbara Cottage Hospital, which is a 519-bed acute care teaching hospital and trauma center. It's the largest of its kind between Los Angeles and the San Francisco Bay Area. We also have Galena Valley Cottage Hospital, a 48-bed hospital, and San Ynez Valley Cottage Hospital, a 10-bed critical access hospital. In addition, we have a children's hospital and auxiliary services. As I mentioned, we're located in Santa Barbara County, where our population is nearly 50-50 non-Hispanic white and Hispanic Latinx. About 13% of our population is living below the poverty line, and there are many areas of high need, including among children and families. As a hospital system, we launched a recuperative care program in partnership with our local shelter in the fall of 2018. And the program has 10 patient beds, a 90-day maximum stay, 1 medical director who's part-time, 3 part-time registered nurses, and a social needs navigator, as well as respite care monitors. And the medical director, nurses, and social needs navigator are all employed by the health system, by the hospital, and then the respite care monitors are employed by the shelter. We partner with our on-site public health care center to serve patients' needs to be their primary care provider. And we also have a program where we continue to follow patients after they leave the program. So they come into the recuperative care program and then we consider them graduates, and we have a graduate program that follows them wherever they may be located. Referrals from the program come from community organizations, local agencies, and hospitals. All referrals are reviewed by our medical director and our social worker. And once patients meet the criteria, we also ask them if they are willing to participate in the program, and we'll accept them to the program as long as they can vocalize a willingness. One unique feature of our program is that we have a component called the transitional care program. And this allows patients to enter the shelter, have a place to recover short term, after their hospital stay, and then be assessed for the recuperative care program. In addition to experiencing homelessness, patients coming into the program need to be alert and oriented and independent in their ADLs, agreeable to their proposed treatment plan, able to self-administer medications, willing and able to adhere to shelter rules, have appropriate acute medical need, and be at a low risk for severe acute withdrawal syndrome. Because we're a hospital, we've been able to incorporate electronic medical record documentation into our program. We launched this by building out a custom referral and documentation encounter in Epic, which is the electronic medical record system that we use. This allows for data tracking and reporting, as well as a tool for communicating with providers, especially if patients re-enter the hospital, inpatient setting, or emergency department services. We developed a comprehensive evaluation around our program, and our recuperative care evaluation as a hospital system, evaluation is really an important aspect of this program for us. With more than 130 patients who have come through the program since we launched in 2018, we intend to address the upstream factors affecting poor health outcomes. And for us, that includes housing, access to care, and in some ways, self-efficacy as well. For housing, our program focuses on helping patients become document ready for housing, and this includes securing personal documents, applying for housing, and obtaining a source of income if they're eligible. We've seen 84% of our patients enter into permanent housing. We also are tracking indicators of patient health and outcomes where possible. Among program participants, we've seen a 51% decrease in emergency department visits and a 58% decrease in inpatient stays during the 90 days following patients' time in the program as compared to the 90 days before they entered the program. One factor in impacting this is their increased use of a primary care provider or medical home during their stay in the program. One factor really impacting emergency department inpatient stays is patients' increased use of a primary care provider or medical home during their stay in the program. We really focus on that with patients and help to emphasize them becoming comfortable with using a primary care provider, knowing the staff there, and really becoming established as a patient in the clinic. We've also learned that it's important for our recuperative care team, including the nurse, the social worker, the navigator, to build strong working relationships with the social worker and the case management team in the emergency department. These types of connections really allow for more efficient communication across teams and streamline that care for the patient. In addition, patients really benefit from the added support, sometimes even having our team accompany them to the emergency department. So it all really works together for patients, and just we find that relationship and connection in with the emergency department from our staff level helps to drive that. We've also really had a main focus, as I've mentioned, on document ready for housing. This helps the patients to become more successful in their transition to permanent housing, ideally permanent supportive housing. Because of a housing shortage and the time it takes to apply for and find housing, we really see that successful outcome as being document ready. And we support this during their stay in the recuperative care program. And then, as I mentioned before, we continue to support them after the program. And oftentimes, this looks like helping them to finish their document ready status and eventually helping them to enter into permanent housing. In terms of a hospital's role in recuperative care, um, as I've gone through with our program and our evaluation, I've highlighted many of the aspects that are important to us as a hospital in the recuperative care space. This includes supporting patients to achieve better health outcomes by addressing the upstream factors affecting their poor health, disrupting that cycle of homelessness with trying to help move them into permanent housing, and then that strong communication and collaboration that occurs between the team that's working at the shelter, whether that team is employed by the hospital or the shelter, and then the team that's working in the hospital. And at the heart of it, I really think that shelters and hospitals share missional alignment because they're both there to care for patients and the community, and both are interested in improving the health outcomes of patients. In addition, the recuperative care team offers support and communication with our staff in the hospital. Our team provides that continuation of care for patients by communicating patients' needs with our hospital staff and focusing on their basic needs after their hospital visit. We really hear positive feedback on this from both our hospital teams and our community partners. And as one partner shared, no matter where cottage patients go, they have had support. This provides the continuum of care that is critical. And throughout this presentation, I've also shared a few considerations that have helped to maintain positive relationships between our hospital teams and our team working in the shelter. And this really includes building relationships between those working in the shelter, including those employed by the shelter, and hospital staff, which can have, I think, really notable impacts on improving daily operations. And having these types of relationships really helps when challenging or unique patient situations arise. To this end, we've also seen strength from developing our recuperative care workflows in a way that plans for hospital team coordination and incorporates their preferences in advance. This is especially for patient referrals and if a patient needs to return to the emergency department. And then I've shared some data that we've found important in our evaluation, and these findings come from open communication on both individual patient outcomes and sharing aggregate data. Um, I know for many shelters that there's not often the advantage of seeing hospital data on their patients, and I would really encourage you to find indicators outside of hospital data. For example, we face a similar situation, not hospital data, but for data we are not able to access. We have challenges in tracking primary care provider visits in our medical records. So our team actually keeps a hand count of primary care visits for our patients in the program. A little bit more tedious, but our team knows the patients, they're working with them, and they're naturally able to find this information when they're working with those patients. Finally, when it comes to funding, it's important to be prepared to speak in language that really resonates with your hospitals. This includes talking with your hospitals about how you can support them in meeting their community benefit goals. I'm happy to go more into community benefit goals and the importance of that for hospitals for anybody who has questions. Hospitals also have deep expertise in Medicaid and can connect to broader philanthropic support. So excited to see that on the agenda for a little bit later today. While hospitals, though, often fund recuperative care beds directly, I do think there are opportunities for shelters to ask for hospital technical assistance for setting up Medicaid reimbursement where that opportunity exists, and then also potentially partnering on fundraising because of the strength that hospitals often bring with their philanthropic networks. And then in California, we're also seeing that our shelters are learning about how to layer funding opportunities. And shelters that bring this type of mindset of funding the continuum of services for patients, so thinking about how do we fund during recuperative care and the days that are after recuperative care, and how do we help support them with that transition, and think about those different funding opportunities that can help fund that. There are a number of opportunities around that with CalAIM, but really a shelter bringing that type of expertise and that type of thinking to the hospital shelter relationship makes that shelter even more valuable in terms of a partner for a hospital because it's thinking beyond that and really helping to, again, address that continuum of care for that patient moving forward. So with that, here's my contact information and happy to answer any questions today and follow up with anybody else afterwards as well. Thanks so much for listening, and I'll hand it back to Caitlin.
Great. Thank you so much, Monica. And just a note for folks, Monica is going to facilitate one of our breakout sessions. So we're not going to do Q&A with the presentations, but please write down your questions and bring those into our breakout group discussions with our facilitators. And with that, Lori, I'm going to share your slides and bring it over to you.
So thanks, Caitlin, and thank you, Monica. I'd love to hear what other organizations are doing across the country. That makes these my favorite things. So a little bit about us. My name is Laurel Nelson. I go by Laurie, so that's fine too. Some of you know me as Laurie. We're located in Cincinnati, Ohio. We currently have 20, we're a 20-bed facility. We're standalone. And we're an integrated clinical care model. We are 21 years into this, and we've had quite an evolution of change and formalizing processes and growing. So our most recent bit of growth was a 40% increase in occupancy. So that was significant. And I'm 11 years in, which is hard for me to believe, but there's been a lot of learning. And what I'm going to share with all of you is some of the things that we've incorporated and how we've evolved with our partnerships with hospitals over the years. So Caitlin, you can go next. So for us, there are a lot of aspects of the hospital relationship to our organization. And I just picked out a few that I thought are immediate and places where you've got to lay some really strong groundwork to go from just a partnership where you're getting referrals. You're getting referrals for your program from the hospitals to pushing to a much stronger relationship. So with referrals, I think what I found most important is that communication with those frontline decision makers. So we have a big relationship with the big decision makers. So these are people in charge of funding decisions. But where you need to make some headway and work on your relationship is with those care coordinators or those social workers who are actually the ones putting together your referrals. We've had incidences at that level with those frontline decision makers that have made or break can make or break what we're doing with that hospital. So I always tell my staff it's burning the candle at both ends, kind of, or working from both ends. And we're trying to have a really strong relationship at that front line with those individuals making the referrals and then their staff. And I'm going to touch on that a little further down in this as well. And then clinical support, you're going to want to have a good working relationship with the clinical piece of a referral. So, you need to make sure you're making friends with those ER docs, with maybe some nurse practitioners or someone in positions that can pave the way for your clinical support. And when I talk about this is all that information you need at the point of referral prior to admission, where you're making sure you can provide the appropriate services and support to that potential admission. And then all of it ties into community collaboration of celebrating that strong partnership you have with the hospital and the areas in which you have that support. So to kind of put that in some framework, community collaboration for us is forging these relationships. They become very strong relationships. And then all of a sudden you have that person on your board and they are helping you every day strengthen that relationship with that hospital. Just a little background, we deal with 5 hospital systems and we have representation from 4 of them on our board right now. So it is incredibly important to lay the groundwork for these relationships. and it's speaking widely about those partnerships. So we do a lot to celebrate those partnerships that we have with those 5 hospitals through things on our website, things that we um, talk about when we're doing any kind of PR, when we're in the paper, when we're on like local news health show. We're continuously speaking about those partnerships. Okay. And Caitlin, you disappeared for a sec, but I think, okay. Oh, awesome. You're still there. So really, I have to share my my wake up moment with forging hospital relationships. In the early days, we had zero funding, zero relationship with our hospitals, still taking the referrals, still staying completely full in our program with 85% of our people coming from the hospitals and zero funding. So one of my first tasks was to change that scenario. So I went and I met with the CEO of the University of Cincinnati Hospital here in Cincinnati. It is our biggest source of referrals. And I sat across from her with all of my documentation, all of my stuff saying how much money we saved that hospital. And she looked me dead in the eye and said, that is not an apples to apples comparison. Those dollars aren't the same. You got to come up with something better if you want funding from me. And then, I had to tuck my tail and get out of there and rethink everything we were doing. So we needed to create a strategy. So that strategy involved understanding the challenges in our community, looking for ways to make this connection between our services and the greatest needs in our community, greatest medical needs. I mean, there's a lot, we address a lot of them, but we were focused on medical needs. So that we had created this platform or this strategy that was going to address the things that were most important to these hospital systems. So we wanted to say there is bang for that buck. We know this is not a dollars to dollars comparison and that it's extremely complex on the hospital side. But how can we prove that our services are going to be extremely beneficial to the hospital and therefore you need to invest in us? And so that had a lot to do with outcomes, which we're going to talk about in a few minutes, and how to determine those. So one of the big things is where to find hospital and community priorities. Well, one of the easiest things, and I tested it out because I haven't had to look at it for a long time, but this morning before we got started, I Googled University of Cincinnati Hospital Community Benefit Plan, and it came up in a first click, which actually is the law, and ACA will tell you you should be able to access any hospital system's community benefit plan. They are required by the IRS to maintain their nonprofit status that they have a community benefit plan. Now you're going to see a pretty high level overview, but one of the big components is going to be community collaboration, and that's where you're finding their priority. The other thing we did is we went straight to the health department and what are our biggest health issues in our community? They were things like uncontrolled diabetes, COPD, because we have bad air here in the Ohio River Valley, and lots of chemicals from P&G. So, we needed to find those priorities. And it wasn't that we changed anything about what we were doing. We changed what we were tracking. But then we also looked for ways to strengthen the partnership with investments from the hospitals that are other than money. So to give you an example, fast forward to establishing this relationship and the investment, not only did it include money from one of our hospitals, it included support to our staff from nursing students who need credit for a public health course and they're assigned to our facility for their entire semester. It included food that we needed to feed our clients, supplemental food, supplies, equipment. We've gotten a lot of equipment through some of these agreements, all the way up to furniture, which was kind of weird, but nice for us. So there's a lot. Volunteers was another one. Training programs that our staff and our clients would qualify for. We're all part of one of these agreements. So you've got to look for those investments that are other than money that indirectly will translate into savings for you later. And so I would start, like, if you need to prove your worth, you need to be matching their priorities. And basically for us, it was just tracking things that were important. We were doing all of these things, but not showing that we were tracking them and making a difference. A big example would be tracking, for our facility, we track A1C. So when someone comes in with uncontrolled diabetes, they're getting their A1C reading, and we're continuously reading it throughout their stay and then reporting that back to the hospital among the patients that were sent to us. That is extremely meaningful. And we can talk more about that when we get in breakout, because I know I'm limited on time. So Caitlin, you can go to the next. And so then it was maintained after we got to the point of investment. So creating that strategy, getting to the investment piece, it was about maintaining the relationship. And this is another lesson learned for me because, you know, I got an agreement, a 3-year agreement, and we went on with our work and we tracked everything and we were sending it, but we were not consistent with our communication. So and then revisiting that agreement 3 years later and finding out none of the decision makers that I struck this agreement with are still working at the hospital because there's a lot of turnover. So we lost a lot of ground, and basically I had to start over from the beginning. Here's what we do, here's who we are, what we do, and how we benefit you. And then months went by before I could get back to that agreement with a set investment, a stable investment. So one of the things we put in place from that lesson learned was asking these decision makers for quarterly meetings so that we meet quarterly to talk about everything that has transpired, where we're seeing some issues, where they're seeing issues, our attempts to resolve them. And I have to share one of the greatest quarterly meetings I just had. This hospital has been, their support has ebbed and flowed over the years, and we have finally gotten back to that agreement with them. And they, in that quarterly meeting, asked if it was possible for us to create a QR code that they could give to their care coordinators and social workers that would link them right to all the details about us, what we do, who we are, where we are, how to make a referral, who to call, here's contact information. And I thought we were using it for all the hospitals. I thought it was the greatest suggestion. And it was so nice to have that feedback from them, signaling that they want to strengthen our partnership and that they want to make it easier for their staff to make referrals to us. Another suggestion that came out of maintaining these relationships is visiting. We do quarterly presentations, or when asked, to groups of care coordinators and social workers, explaining our program, answering questions they may have, and helping them view us as a very significant resource for their placement. We've also, upon their suggestions, started to visit patients in the hospital. So between referral and admission, we were tracking and realized we were losing a lot of clients between that acceptance and admission. So the hospital thinks they're coming, we think they're coming, and they never show up. And then we're like, why is this happening? Well, there's a lot of fear. So we started visiting these potential clients in the hospital, face with a name, and somebody who would be there to greet them when they came in. It eased a lot of that stress and tension of coming to a new place. And we went from about 35% of the individuals we lost between referral and admission. We dropped that number from 35% to less than 10. So we really made an impact. In that the hospital was appreciative because their work was futile. Our work was futile. We all wasted a lot of time for the person to not end up coming. And so then maintaining that relationship is consistent outcome reporting. So we found what was important to them. We asked them what they would like to see. We built in some mechanisms to track those outcomes, and they get reported on a quarterly basis, whether or not we have that meeting. So that is very important to keep them aware of what you're doing for them. And among the key data points, one of them specifically is what happened. So I think a lot of times you lose your hospital investment, you lose if you never tell them what happened to these individuals. So we're very careful about reporting on success. So they went to a nursing home, they went to an assisted living facility, they got their own apartment. And of the individuals you sent to us, this percentage went to stable placement from our facility. It's meaningful. It's very meaningful. And then, of course, PR opportunities. Every time I get asked, and my favorite thing in the whole world, to go on TV and talk about our program, I'm sure to mention the hospitals and our relationships because they love that. That is significant. It speaks right to their community benefit plan and what they are doing for the community from another partner. So always look for those. We use our website, we use our social media, we use any written publication or any media event to talk about those partnerships. All right. I think that was the extent of my slides. I think I'm a little ahead too. I think I flew through that. So I'm happy to answer any questions. Caitlin will be sharing my contact information, and I'm happy to talk to anybody anytime. I love doing technical assistance. I could talk about us all day long.
Fantastic. Thank you so much, Lori. And yes, our timing is great, which is wonderful because we're moving into breakouts and it's the first one and we just know that it's going to be a little bit clunky. So thank you for the extra few minutes to describe it. So in a few moments, I'm going to open up the breakout rooms. You'll have 3 different options and please select the breakout room that makes most sense to where you are in your program is right now. So breakout group room 1 is going to be really tailored towards new and developing programs. If you're really at the beginning phases around developing these hospital partnerships and funding partnerships, that breakout group is going to be facilitated by Elizabeth Kelly, who has a wealth of experience in that area. Group number 2 or breakout room number 2 is going to be for folks who are maybe newer or more established, and you're really kind of where Lori just spoke about when she entered her program, transitioning from that we take referrals into we would like to have a little bit of funding or extend out this partnership further. So Lori is going to be facilitating that conversation. If that's where you're at, please join breakout group room 2. And then group 3, breakout room 3, is going to be for our established programs. Perhaps you have a relationship and we're really going to be thinking about how do we maintain that relationship? How do we negotiate for growth or doing things beyond what we're doing? And that room is going to be facilitated by Monica Ray. So lots of time to kind of dig in and pick the brains of these experts. So I'm going to open the breakout rooms. You can, ideally what will happen is that a pop-up will come and you will be able to move yourself into the room by finding group 1, 2, or 3 and clicking join. If it did not pop up for you, you can look at the bottom of your screen and there at the very bottom right, it says more and has 3 little dots. Sometimes you need to click that and the breakout option will come up for you to be able to join your room. So please feel free to join the room that makes the most sense for you and where your program is right now. And if you are not able to self-join, we will work on getting you all into your room. So facilitators, please give folks a moment before you dive into conversation, but I am going to move you first. And someone from my team, it did pop up, right? There's an option for people to move.
Yes.
It didn't pop up for me, Caitlin.
I have not.
Yeah,
I'm not
I
seeing.
didn't get a pop-up either.
Oh, there we go. Okay. Did the pop-up change now? Did it come up for anybody?
It's in the bottom right corner on mine now.
Okay.
I could be missing mine. but I still don't see it. Mine.
It went away very quickly, Taryn, and it was a small little box over where it says leave, if that's helpful to folks.
Thank you, Sam.
Mine now shows up, Taryn, if you click the more like Caitlin suggested, there's transcript, captions, and then breakout rooms.
Got it.
And
That was
for
very
folks-
helpful. Thank you.
Thank you, team. For those who it has not popped up or you're still having trouble, please feel free to put into the chat and we'll work our way through moving you into the room that you would like to go into. Just give us a moment. Folks are very diligently on it. Carlos, which room would you like to go into? I can move you.
Dealer's choice is fine.
I see you folks in the chat. Thank you for letting me know. But you should have a pop-up to join soon. Anyone else not able to move into their breakout room that they would like? So we're just closing out the breakout rooms. I think most folks are transitioning back in, but we'll wait just a few seconds here to make sure the conversations get wrapped up and everybody is able to come back and join us again. All right, so I think we are all back together. It looked like those were some pretty fruitful discussions. So I hope that you were able to learn a lot or maybe dive in a little bit deeper about things that don't normally get to talk into. I just want to note we have several resources available around partnering with hospitals and hospital systems. And so all of these links were going to be posted with the PDF of the slides on the registration page, which you will all get as an email follow-up. So just know you'll be able to access all of these links as soon as we have these slides posted. We also have our contact information for all of our presenters and facilitators here so that you might be able to reach out to them with additional questions. So with all of that, we are going to move into our next conversation about Medicaid. And I'm going to turn it over to Julia Dobbins, who's going to lead us off in that conversation.
Hi, everyone. My name is Julia Dobbins. I am our Director of Medical Respite here at the National Healthcare for the Homeless Council and with the National Institute for Medical Respite Care. I have been with the council for 12 years and I'm based in Nashville. And I was just thinking, I really hope that you can't see my face very well because I don't think I'm the only person in this room, but I have developed over the last week to 24 hours an uncontrollable eyelid twitch that's just like continuously going. So if you notice that, everything's fine. Google tells me it's screens and stress. So but again, I feel like I'm probably not the only person experiencing that right now. I'm going to talk a little bit about Medicaid as it relates to medical respite care. And I want to preface with just saying that everything I have learned about Medicaid, I have learned from Barbara DiPietro, our Senior Director of Policy, and most of it has been against my will because when I started working in medical respite care, it was not my expectation that Medicaid would become such a big piece of medical respite operations, but it really has. And it's important that we as a field in medical respite care understand our state Medicaid, understand managed care, and understand how that impacts our programs and our patients. So I'm going to dive in here. Caitlin, next slide, please. So how Medicaid came to be a part of the medical respite funding story really starts with the Affordable Care Act and the expansion of Medicaid. So basically what happened was we had the opportunity to expand Medicaid to single non-elderly adults living in poverty. This drastically opened the door for more folks to have Medicaid coverage. For a lot of states, the percentage of their folks covered with Medicaid doubled or tripled in size. And that's for the states that decided to expand Medicaid. Part of the benefit of expanding Medicaid for single adults too was that the federal government increased their match rate. So it seemed at the time for a lot of states a no-brainer. More of their community members were going to get health insurance coverage, and the federal government was going to match rates at an astronomically high rate. So most states decided to expand their Medicaid, and in doing so, expanded the number of people experiencing homelessness in their state having Medicaid. Now, there are a handful of states that are really hanging on and have decided not to expand their Medicaid. I live in one of those states. This is not my choice, but I live there. And those states are reflected in the light blue here. So for any of you who are living or operating services in those light blue states, hang tight for about 10 minutes because this is not as relevant for you because so few of the people experiencing homelessness in your state are covered by Medicaid. But for all of you in the darker blue states, there has been a lot more opportunity around Medicaid funding for medical respite services, and I'm going to dive into what that looks like. Next slide, please. So how it first began, all of these state Medicaid agencies, many of them are partnering with managed care, Medicaid managed care plans. So these Medicaid managed care plans had a bunch of new members now, many of them, or some of them experiencing homelessness that they had to figure out how to provide services for. And they were starting to see the benefits of medical respite programs. We know that medical respite care provides a safe place for people to be discharged and connected to resources, that medical respite can have a long-term impact on people's health and access to health care. And so individual medical respite programs started building relationships and negotiating contracts with individual managed care plans. And that's how this really began. That was in like 2014, 2015, 2016. Programs started developing relationships with their local managed care plans. Now, every state is different in what their managed care looks like. For some states, like California, that's a little bit more complex. They have different managed care plans based on the county. So for example, Los Angeles County has 7 managed care plans. And while other states have managed care plans that cover the whole state, so there might be 7 managed care plans in the entire state. So what medical respite programs were doing is reaching out to these managed care plans and starting to negotiate a contract of, if your member comes into our program, will you reimburse and support the medical respite services? So this slide gives an example of what those types of payments were in the early days with medical respite programs contracting with Medicaid managed care plans. And they looked like per diem rates, it looked like a per member per month rate, a one-time case rate, pre-purchased beds. So the managed care plan might pay an annual rate and say, we would like for you to hold these 15 beds for our patients, for our members, and we will keep those beds for the year and then renegotiate every year. Also, all of this information I'm referring to is a resource that we have on our website that Barbara actually worked on in partnership with United Healthcare. So you'll get a link to those resources. Next slide, please. Additionally, for all of the negotiated contracts, there were different definitions of what was reimbursable within that. So what was the bundle of services that the medical respite program was providing that the managed care plan was going to be reimbursing for? And that depended on the program and what was being provided. I think the clear thing across the board, and this is such an essential component of all medical respite programs, is that case management, social service support piece. So yes, it is a safe place to rest and recover. Yes, there's some clinical oversight, but really a core component of all respite programs is connection to other supportive services. So this slide outlines what medical respite programs negotiated with the managed care plans that they would cover in their daily rate, per member per month rate, annual rate for their medical respite beds. Now, it's important just to clarify that at this time, no state, not a single state, was reimbursing for medical respite care. It was not a reimbursable service. So how the managed care plans were paying for this service was from their administrative dollars. So that was really the choice of the managed care plan to invest in the medical respite services. There are some real strong benefits to this, and this is still an option for a lot of your programs to work with your individual managed care plan on how you can contract with them to support your medical respite services. I think one of the downsides of this avenue of Medicaid reimbursement is it's a different negotiation process with each managed care plan. So you might have one plan that agrees to a certain daily rate, one plan that agrees to a per member per month rate. So it's just a lot of administrative work for the medical respite programs to be negotiating several different contracts. So that takes us to the next step in our Medicaid journey here. Next slide, Caitlin, which moved us from plan-driven reimbursement now to state-driven reimbursement. So we've started to see, instead of having programs negotiate individually with managed care plans, we now have the option of how about states create a medical respite reimbursable code. So it is now applicable across the state that all medical respite programs are able to contract with managed care plans and then reimburse for medical respite care. So the first state to move forward with a statewide plan was California, and California rolled out medical respite reimbursement in 2022. And so California has a few years under their belt of reimbursement for medical respite services. After California started, it has been a cascade of other states following in California's footsteps. This image has changed. I mean, we did this in December of 2023. We're working on an updated state of Medicaid reimbursement for medical respite right now. But there are several states that are moving in this direction. So we know California, Washington, North Carolina, New York, Massachusetts, Hawaii, Illinois, all of these have an 1115 waiver approved that includes medical respite care now. And there are other states that are in the process of pursuing reimbursement for medical respite care. Now, just to keep it complicated and interesting, which we love to do in medical respite, every state is doing this a little bit differently. So some states are going through an 1115 waiver process, and an 1115 waiver is a demonstration waiver that can be 3 to 5 years, and it basically creates an opportunity for you to use your Medicaid dollars in innovative ways to demonstrate a new way of providing care to folks on Medicaid. And then other states are going about it in a different way. So they might be doing like a state level amendment. They might be doing legislative work. So it just depends on what makes most sense politically, I think, for each state. So we're tracking the progress of this across the country. And there are a couple of things that I want to share around lessons learned over the last couple of years that you can take back for your state. Next slide, please. So what we learned from CMS for the states that are pursuing an 1115 waiver for medical respite care, CMS basically told us, we've approved this language for these states, and so let's keep using this language. So if you are in a state that is considering pursuing an 1115 waiver for medical respite reimbursement, this is the sample language that other states have used that was approved by medical respite care. Next slide, Caitlin. And as Caitlin shared earlier, we're going to be sharing these slides, so feel free to, don't worry about taking a screenshot of it. You'll have this information, but really encourage you to use this language in the development of your services because we know CMS has already reviewed it, they've already approved it, and we know that it works. Now, I think the through line across all of these applications is we're seeing generally that medical respite is including this bundle of services of these supportive services that come into medical respite. So care coordination and case management. The room and board piece is a little complex because technically Medicaid cannot reimburse for room and board. However, we know room and board is an essential component of medical respite care. So that's a little bit of a sticky piece here within the Medicaid language. The other piece that we're seeing around length of stay is we're starting to see some agreement around up to 90 days is the language that seems to be being approved. Now that has just recently changed in California where they're saying up to 6 months for recuperative care. And I think Illinois is also looking at up to 6 months, but generally what we're hearing is up to 90 days. Next slide, please. So we talked a little bit about this in the breakout room I was in around hospital funding. What are the benefits of Medicaid funding for medical respite programs? I think we've been looking at Medicaid reimbursement for medical respite for so long because we have seen it as a sustainable, consistent funding source for medical respite programs. And it has turned out to be that for many programs. What we've also seen in California, what has been shared from medical respite programs and from plans is that there seems to be more understanding between medical respite programs and managed care plans about what each other does. So there's improved support. Patients are getting access to more services, patients and partners are more informed, and there's better integration between the systems. I think the challenges that we are seeing, some of these anticipated and some of them not anticipated, is that when we move a service like medical respite care, which is sort of a scrappier, I say that with love and respect, grassroots service into a Medicaid structure, there is a lot of bureaucracy and there's a lot of administrative burden. So medical respite programs are now having to bill managed care plans and have like a billing department at their medical respite program. And sometimes the claim that they submit are denied. And so then they have to go back. And so there's just a lot more administrative work than I think we originally anticipated. Also, there have been some challenges with low reimbursement rates, with higher clinical needs than the medical respite programs are able to address. And if somebody's in medical respite for only 90 days, an expectation of somebody being discharged to housing is really hard to meet for most medical respite programs because of the scarcity of housing across the country. Next slide, please. Some additional lessons learned, and this is from the plan's perspective, is that, again, increased partnership and understanding each other's roles and relationships and the workflow. And we're allowing folks to receive better care from the managed care plans. And there's been some frustration that medical respite programs don't have the level of capacity that the managed care plans wish that they had. We know that there's always been a challenge of getting our folks into skilled care, but that there's really been a light shown on that in this rollout of Medicaid reimbursement. And then again, this just general frustration around lack of housing. So I say all of that to say that I think I think I'm gonna mix metaphors. I was gonna say the cat's out of the bag, but then I was gonna say the train's out of the barn. Anyway, things are moving with Medicaid. We're not gonna go backwards as it relates to Medicaid reimbursement for medical respite. So what we're trying to figure out is how do we do this well, and how do we understand, or how do we work with the reality that Medicaid reimbursement for medical respite services is not this gold star, you've saved us from all of our financial challenges solution that we thought, some of us thought maybe a little, a little green, thought that that Medicaid reimbursement was going to solve all of our sustainability challenges. And it's turned out that's not true. Rates are not as high as we had hoped they would be. Administrative burden is expensive, frankly. And there are still a lot of workflow issues to work through. Next slide. So one thing that I do want you to take with you, and this is a resource that we will share, we've developed some principles around Medicaid reimbursement, and we believe this is really our standard of care for how Medicaid should be working with medical respite programs and what you should be advocating for when you negotiate with managed care plans. And we're also trying to bring this language to the state level with state Medicaid and in our conversations with folks who are in the process of developing 1115 waivers or implementing 1115 waivers, but really keeping in mind the actual cost of medical respite services. So that is a key to have in your, a key thing for you to have is to really know what your actual cost is, what your daily rate is, so we can make sure rates are set on the reality of what it costs to offer services. Yes, it is cost savings for a lot of for the health system in general, but it's still not cheap to provide medical respite services. We're talking about folks who are very sick and need a lot of support. So I think it's important not to undercut ourselves. We want to make sure that they're based around the standards of care. We want to make sure we're including behavioral health and not separating out medical and behavioral. Medical respite programs should be providing services related to behavioral health. We are whole person care advocates here, and so the rates need to reflect the behavioral health services being provided in medical respite. And I think it's also important that we hold the uncomfortable conversation around tiered payments for medical respite services. We all know that not all medical respite programs provide the exact same level of clinical services, that there's models of medical respite care and that the costs are not all the same. So how do we really think about reimbursement in a way that's equitable for the services being provided? Next slide, please. So that's my quick overview of how we got here with Medicaid, how Medicaid came into the medical respite world, how we have grown over the last couple of years. I think it's 14 or 15, maybe more states now that are looking at Medicaid reimbursement. And now we're in this place of, I'm sure there are folks on this call who are yeah, but what about me? So for our non-expansion friends, I say this as a member of a non-expansion state, this is a harder conversation. It is, I don't know how successful it would be for you to go to a managed care plan and say, hey, you should be reimbursing for this service. Only 15% of your members are experiencing homelessness, because most people experiencing homelessness in non-expansion states don't have insurance. But there are other avenues here, and that's something we're going to explore in one of our breakout groups is how can we get some of our uninsured folks in non-expansion states, how can we get them on Medicaid? Many of them qualify for Medicaid. It's just the process of how do we help them get the needed health insurance that they qualify for. There are also states that are just not going to be pursuing an 1115 waiver anytime soon. Either politically, it's not going to make sense right now, or maybe they're already in an 1115 waiver that's in year 3, so it's going to be a while before you come back to it. So what are the options for those folks? Then there are states that have pursued this, have reimbursement, and it's really frustrating and not going well. That is a reality in some spaces. I think we have not we have not perfected what best practice looks like for Medicaid reimbursement yet. So there's still a lot of work to do together around how do we want this to work well for our programs. And then I think the biggest question hanging all over all of our heads right now is, this is all great to talk about Medicaid reimbursement for medical respite, but what is going to happen to Medicaid in the coming weeks? And what if Medicaid expansion is undone? And all these folks we're talking about who are covered with Medicaid are all of a sudden not covered with Medicaid. So then what does that mean? So I don't have an answer to that. I sit with you in that anxiety. It is making my eyelid, um, twitch uncontrollably. And at the end of the day, medical respite services are still going to be needed, and there are partners that we can develop to figure out how to fill those gaps. So we're going to move now into our breakout rooms. Caitlin, how am I on time? Are we okay on time?
We're good on time. Yep, we're right where
Okay.
we need to be.
Perfect. So I want to talk to you a little bit about our options here for our breakout groups. We have a lot. The first breakout group, so room 1, we're going to dive into SOAR, so SSI, SSDI, Outreach, Access, and Recovery. And this is really geared towards programs that are in non-expansion states. Anybody can join this breakout group, but really thinking about, we have folks in our program who are not covered, who don't have Medicaid. Medical respite is a great space and opportunity for folks to work towards getting folks their disability if they qualify for it. So we have a great resource coming out soon about how medical respite programs can do SOAR work while with their patients while they're in medical respite. So highly encourage you to join that conversation if you're interested in that piece. For the second one, contracting with managed care organizations. We've got our friends at Quantified Ventures who have just done a wild amount of work around how medical respite programs specifically contract with managed care plans, the structure of the contract, what needs to be included. They have a lot of expertise around that. A lot of medical respite programs have a lot of anxiety around negotiating a Medicaid contract. So I think that would be a great conversation for you or your organization if you're interested in, how do I partner with a managed care plan? How do I negotiate a contract? What do I need to keep in mind? And what do I need to know about what their priorities are? I know we have some folks on the call from California. California is very unique and specific with their CalAIM project for Medicaid reimbursement for medical respite. So if you have questions about what's happening with CalAIM, some of the recent changes, some of what's coming up, I encourage you to go to the third breakout group. That's going to be a California-centric conversation. Similarly, Washington State is just on the cusp of rolling out their Medicaid reimbursement structure this summer. That's going to be going into place. There's a lot of conversation to be had about how do we learn from California and what they've done. What do we want to do now to prepare for this rollout? So if you're based in Washington State, I encourage you to go to that conversation. If you are in a state that you are interested in pursuing an 1115 waiver, if you want to learn more about what an 1115 waiver is, how that could be used for medical respite, I think the other piece around 1115 waivers is you can use an 1115 waiver for multiple activities. So any health-related social needs, potentially, if you want to do some housing work with an 1115 waiver, that would be a good partnership between you and some other organizations in your state. But Barbara and Ann are going to be in that room, and just Barbara knows everything about 1115 waivers and how to write them and who should write them. And so if you're interested in an 1115 waiver, I encourage you to join that group. And then Sam and I are going to be the catch-all of the I don't fit in any of these categories. There are some states that skipped the 1115 that are, like Minnesota is doing its own thing with its state work. There are other states that are looking at legislative actions for their medical respite services. And then there are states where it feels like I don't fit any of these. So please feel free to join us in group 6 if you feel like you fall into that category or you just don't know where else to go. We'd love to have you.
Great, thank you, Julia. So I'm going to open rooms. Hopefully it'll work just a little bit better this time around. We're always learning, but same process. should be popping up for you to be able to join your groups now. The labels now match what's on the screen. But just as a reminder, if it didn't automatically pop up for you, there might be a box down at the bottom or 3 little dots to click more to open that. And then if you need some help moving into the room that you want, please feel free to put that into the chat and we will try to get you situated where you would like to be as soon as possible. So Francis, I see you. I'll get you to where you want to go. Raven, I'm trying, it keeps moving on me, but I'll get you to 4. All right, I think we have most everybody back for breakout groups. We probably could have hung out in our breakouts for another 30 minutes, but that is the complexity of Medicaid. So more to come for sure as things continue to change. Because of that complexity, we have many related resources regarding Medicaid, MCOs, medical respite care. So again, these slides will all be posted and shared out to you after this event. So you'll be able to click and go directly to these different webinars and publications that we have available. Also included in these slides is the contact information from all of our fantastic facilitators who shared all of their knowledge during our groups today. So you are able to find their information here and reach out to them directly. It has been quite an afternoon or morning, depending on what time zone you are in. So we are going to do a break. We are going to resume at 3:20 Eastern. Subtract yourself wherever you are across the country. I'm not going to do that on a public recording. I've embarrassed myself that way before. So please take some time to take care of yourself, clear your brains, get some fresh air, and we will be back at 3:20 to talk about grant funding and fundraising. Thank you so much, everybody. Perfect. All right. Well, welcome back, everybody. I'm super excited for our next presenters to talk about fundraising and grant funding, something that as I was putting the symposium together, I realized we don't have a ton of resources on around this for medical respite care programs. So super grateful for our presenters today in sharing this information. I do just want to make a quick note that we do not have a breakout group discussion after this presentation. We're going to do kind of Q&A and discussion all together as a large group. So as Liz and Kasha are presenting, please feel free to put your questions in the chat and I'll keep track of those for when we have the Q&A time. We can get the conversation started with those. And with that, I will turn it over to you all. Thanks so much.
Thank you. Well, I'm just going to quickly start. And Caitlin, I didn't tell you I was going to do this. But before we begin, I was just wondering if there was a way to utilize the chat to ask everyone very quickly in the room. I see there's about 85 people to share with me really, their experience with fundraising. So are they beginner, intermediate, or expert? So maybe what we could do is say beginners 1, intermediate is 2, and expert is 3. I'd love to just get a sense of everybody's experiences. Seeing a lot of 2s, 1s, at least 1 3. Vanita, feel free to jump in and present with me. Same Carly, I'm happy to have you do that. Solomon, anytime you want to jump in. Andy, I am by no means an expert. Nancy, okay, I see 3s. Okay, I'm just seeing, okay, perfect, thanks. I think we've got a lot here, but grants, not donor development. All right. So I'm going to start and I'm going to, of course, introduce my colleague. I want to introduce Kasha Shah. And our organization is Path Forward. This says Pathways. There is another organization that is Pathways, and that's fine. Thank you for moving the slide. That's great. We are Path Forward. We used to be known as A-SPAN, but in 2021, we rebranded to become an organization that really focused on the comprehensive services that we provide in order to move people from a place of difficult time to stability. And so I'm really pleased to introduce my hero and colleague, Kasha Shah. She is our nurse practitioner and vice president of medical services. Kasha, I'd just love for you to just say hello and give a little bit of background on your work.
Yes, I'm sure, hello, everybody. I'm sure I've been on other calls with you in the past, but I've been with Path Forward for almost 10 years now. And ever since we've started, we've just really developed and enhanced our program. Our medical respite program is unique in itself that it is a county program, and we are a nonprofit that is contracted by Arlington County to operate this medical respite program. So that comes with its unique challenges itself. We are very small. We're just a 5-bed private rooms, but we are embedded in the shelter. So we also provide medical services to those that are in the regular shelter beds. That's a 24/7 residential shelter in Arlington. So we provide services not only in medical respite, but we also do street outreach, shelter, and we're also expanding into our permanent supportive housing to keep those folks successfully housed, especially the ones that are medically fragile.
Thank you, Kasha. All right, Caitlin, I think that we can move forward because I know I'm hoping to make this as much of a dialogue. I know you're going to keep track of the questions. I almost want to whip through these so that we can, we can talk as a community. I think I know that I jumped on and I heard, some discussion earlier when I just kind of decided to sit in the waiting room around what's happened in the last 24, 48 hours. And I think everybody's been shaken by this. And I think that for me, as I put this presentation in perspective, it's truly why considering how you diversify your fundraising program is going to be essential moving forward. There's just no doubt in my mind that we're going to have to look at all streams, especially for those who rely heavily on federal sources and other government contracts and grants. So for this presentation, it's my hope that we're going to be talking about real strategies to diversify your funding. And because this is only, let me just remind you, it's a 30-minute session with, I think, 10 minutes of Q&A, correct, Caitlin? We want to make sure that I can't go so deeply into how you do this, but I'm going to just talk from a general sense of the different ways that we fundraise at Path Forward. I'll also talk a little bit about, how you can build some fundraising plans tailored for long-term impact. And I'll dive a little bit deeper into grants, how we go after grants, what we look for, and the kind of stories we tell. So thank you. If I'll go to the next slide. Am I moving the slides, Caitlin, or are you going to be? You're good? Okay, good. So I'm just going to share briefly. Kasha touched on our work. You can see our vision and mission here. I'm not going to read it for you, but very clearly we want to end homelessness, especially in the Arlington community, but nationally. We want to see an end to homelessness. People deserve the right to live free from that horrible, traumatic burden of homelessness. And so our mission is to foster stability and dignity through transformative services and housing solutions. Thank you. We can go to the next slide. I just wanted to quickly introduce you to our comprehensive services model that Kasha touched on. While we have the medical respite program in our homeless services center, which is also home to our 50-bed shelter program, our largest area of program is actually housing. And so we have clients in well over, I think, Kasha, 130 apartments scattered throughout Arlington. And what we're learning is in order to keep them in housing, they need to have holistic care. They need to have wraparound services. And so Kasha, with her incredible vision, has been pushing us to expand our mobile medical program into housing. But you can see that wrapping around every area of our programming is case management and medical services. Happy to come back to any questions. We can keep moving so that we can hit the meat of the information here. Okay. Kasha, do you want to, I think you already talked about our medical respite program. Do you feel like you want to add anything else about it?
I think it's just important to note that the other unique thing about our medical respite is that the funding for it is primarily for the additional services that we go above and beyond for our clients. A lot of that is fundraised and from our local donors too. We don't have Medicaid reimbursement. Which comes with its own challenges, as I'm sure as you have all discussed previously. So I think that's the biggest part but our medical respite program, we would try to make it a comprehensive, well-rounded program to address all of the clients' needs, not just their immediate medical.
So as Kasha mentioned, I mean, we do have some funding from Arlington County for this program. We also do get some partner organization reimbursements from other nonprofits that perhaps provide us with reimbursements to for medical services. And so, but there's a delta. And honestly, this delta is what's on the books. But I just want to share with you that Kasha goes way above and beyond for all of our clients and especially our clients in medical respite, as does our nurse Theoma. We have a nurse Theoma who, some of the county contract covers Kasha's, salary, but not even close to all of it. And then of course we have an RN who's completely privately funded through our donors. Okay, thank you. So how do we do this then? Where do we pick up when all of our programs have a delta between the government contracts and grants? And you can move on to the next slide. So fundraising is everything. So I just wanted to share, this is so basic, and again, we can get into it in the conversation, but there are really 4 essentials. You have to have a process. You've got to have a process. I have worked in nonprofits for, I'm not going to say how many decades, and I've worked in a startup children's museum where we had no process. And I will tell you that those were the hardest 4 years of my life. You have to have a structured plan that leads to successful fundraising. Prospects. Everybody on your team has to be involved in identifying prospects. That's not just if you are a nonprofit with a board of directors, that's also your program staff. Kasha, is so busy, but I always plan to jump into her brain and ask her who she's connecting with. I will also say that what we're going to talk about in kind when we get there, so let me not jump ahead, but you need everybody to help you engage a wide network of supporters. People, it's all about relationships. People give to people. Yes, people give to missions. Yes, people give to important causes, but they also give to people. Relationships are everything. And then you have to have a well-crafted plan. I will tell you that there's a lot out there on how to create a development plan. And I'm happy to send some resources to Caitlin after this session. But you do need to have a development plan if indeed you are seeking funding from private, public, corporate sources. Okay, we can go on to the next. Did I hear something? I'm sorry, Caitlin. I know. Okay, so one of the things that Caitlin and I discussed is how do you build your infrastructure? Who do you need? Well, again, I'm assuming that some of you are on nonprofits, working for nonprofits. Obviously, you need a staff. You can see that at Path Forward, we have our CEO is very much involved in our fundraising efforts. She manages the very top tier of what we would call the donor pyramid. So those are the top givers who are very involved in the community. She's known them a long time. She's very much involved in that. She's helping me today because we have a deadline for corporate sponsorships on Friday. So she's reaching out to her contacts. The DoD is the Director of Development. You want to have someone who's in charge of your efforts. In my case, I'm the Vice President of Philanthropy. My responsibility is only major donors for individuals, corporate, and foundations. So our Director of Development is leading our team, and that includes people who oversee communications, one person, volunteer coordinator, and then we also have a community outreach manager. We actually outsource grant writing, and we're going to be outsourcing management of our donor database, which is a pretty hefty project because we just currently don't have that on staff. So who else do you need to have in your infrastructure? Who else will help you raise money? Your program staff. You need your program staff to understand where they fit in philanthropy. And one of the things that we're intentionally doing at Path Forward is building a culture of philanthropy. With our new director of development who started in October, we're working heavily to help our program staff understand how they fit in, because everybody is responsible for bringing in funding and everybody plays a role. And it's not a scary thing. It's simply how you greet a volunteer or a donor when they come in. Okay, somebody just, should I wait to answer the questions, right, Caitlin? I saw the
Yeah,
question
we
pop
can-
up and I'm like squirrel. Okay. Volunteers, you need volunteers. Your board of directors, if you're a nonprofit, it is the fiduciary responsibility of a board of directors to help you raise money. There are different types of boards. There are governing boards and there are working boards. Working boards tend to be for nonprofits that are smaller, very much in the weeds. Path Forward is very lucky that we've grown to have a governing board that helps to set policy. But just because they set policy doesn't mean that they are not being asked to help us. I am emailing them today to remind them that the deadline for sponsorships is Friday for our big event in April. Committees, we actually have 2 committees that help us raise money. We have a special gifts committee, which is major gifts. They're reaching out to individuals and organizations, corporations. And then we also have a committee that's planning our fundraising event in April. And there's a lot of overlap between those 2. So you need to make sure you have one person who's responsible for coordinating all of the information between those 2. That in this case is me. And so both committees reach to me before they make any asks. We have councils at Path Forward. These are non-governing groups. We have an advisory council of people who are community influencers and really have long arms in the community. They are not the board, but we lean on them for advice. We inform them every year of what's happening at Path Forward, and they're really incredible advocates. Program volunteers, if you have volunteers, and then also community advocates. Those could be people who are elected officials. Those could be other people in the community. I mean, I can tell you that Kasha has an incredible group of advocates from the medical world who support her as she's working to build our programs out. So we can keep going. And Kasha, if you want to jump in at any moment, just feel free. Types of funding sources, I'm not going to go through every one of these. We can take questions at the end. This is really Path Forward's types of funding sources. We do receive federal, state, and local government grants. We are lucky to be working with 2 community foundations, Northern Virginia and Arlington. We are really actively pursuing health-focused foundations for the build out of our mobile medical program, which currently all of that funding is private. Family and private foundations. They're faith-based. Our biggest area for Path Forward in fundraising is individual. It is the largest piece of our pie. It's close to 80%. I'm sorry, 60% of our fundraising has to come from individuals. And within individual fundraising, there are all types of areas to consider. You know, we can talk about this when we get to questions, but seed funding, you know, if you have a special program, Kasha had a special program a few years ago that she was able to get some seed funding for to start a foot care clinic. You need to be considering giving programs and levels, major donors, mid-level donors, annual fund donors, people who maybe are sustainers who give monthly donations are really important to sustaining your cause. And then where else can you get funding? Volunteers. Don't just think of volunteers as people power. Think of how you can actually help to make them, convert them into donors. And maybe it's just a $10 a month donation. Kasha is the queen of in-kind donations. Kasha helps us with many organizations that give us medical things, and I'm sure she would be able to share some when we get there. I'm making sure I'm checking the time. I need to speed up a little bit, but in-kind donations at Path Forward are very important because for some of our government contracts and grants, we actually have to track them because we have to provide a match. So I don't know if anybody today is on the call that actually has corporate or I'm sorry, government grants where you have to provide or a contract where you have to provide a match, but some of our in-kind donations can be used towards those match. And Path Forward accepts clothing, wheelchairs, medical supplies, insure, diapers, adult diapers, all kinds of things that can help us because then it's a way to offset your expenses and you're not spending the money on that. Earned income is something that's very important for nonprofits to consider, and that is do you have a service within your mission that you could actually charge for. So for example, if we had the capacity, but we really kind of don't right now, we could have a nurse that could be hired by other nonprofits to have us come in and work with their clients. So think about different ways that you could have a fee for service program. Maybe you have expert case management and your case managers have certain certifications. Perhaps you could have them go to other nonprofits and as a fee for service train other folks. So that's just another idea. And then of course, events. We have a major fundraiser on April 10th, but we also do what we call third-party fundraisers where a restaurant may do a roundup campaign. And then we have people that do peer-to-peer like fundraising dinners, or I've had people who even ask for their own donation link and then they send it to their friends. Okay. I'm going to quickly go through the donor cycle, and I'm happy again. I'm sure you'll be sharing these slides and my contact information is at the end. It's really important to understand both the donor cycle and the donor life cycle. So in terms of donor journeys. And so what I want to share is that this shows it like a circle, but it's not. It's not. It truly can be something that you are, it's not like a point, you know, one, first you do this, second you do this, three you do this. But in terms of the donor cycle, you know, obviously if you are new to fundraising, at that top you see the magnifying glass. That is for you know, research. You need to research who your donors could be, whether they're funders, grant funders, corporations, individuals. The next, you need to qualify them. That's more of your research. You need to make sure that they have the capacity. And how you do the research can be including your board members, including your fundraising committees. They can help you qualify donors. Say, does this person have the capacity to give a gift of this size? The next bucket, and I realize I forgot to put those words, that is cultivation, where you're talking, where you're getting to know these donors, these prospective donors, and sharing your mission and vision with them. You're hearing about what's important to them. The next bucket is your solicitation with the little plant, so asking them. And then we also have with the hand, with the heart, stewardship. Stewardship is everything. For those of you who are very familiar and engaged in fundraising, stewardship is how you provide value to your donors, how you thank them, how you share the impact of what you do. This is where you have to spend your time. If you don't have donors, spend your time in research, qualification, not as much, but cultivation. But if you have donors, spend a lot of time on stewardship. And again, this cycle continues. Once a donor is already within your world, you want to make sure that you're getting their feedback. Are they happy with your programs? Are they happy with how you've asked them for money? Do they have certain communications preferences? Would they prefer a text over a letter? Do they not want to get your letter? Then when you're starting to talk to them again in that next year, could you consider an upgrade? You know, ask your donors to consider an upgrade. But again, it's constantly going through this cycle with your donors to ensure that you keep them in the loop. A lot of organizations receive first-time gifts and never steward their donors, and then those donors do not come back to make a gift again. Okay, there we go. Back to, I think now we're on to grants. Grant opportunities. There are many sources out there for grants. We use a program, it's a paid program called Instrumental. Some people use Foundation Center. You can actually, some libraries have Foundation Center. So if you have a library membership, you can go and use their foundation directory. If you aren't on GuideStar, look at GuideStar. Here's the trick with GuideStar, which is also known as Candid. If you go onto GuideStar, you can look at the 990s of nonprofits like you across the country and see who is funding them. Or you can look at service providers like you in your area, look and see who is funding them, but also look at their websites, also look at their annual reports. Make sure that if somebody attends their event from your board or a staff member attends an event, bring back the sponsorship booklet. And then the last resource there is the Council on Foundations, where you can look up community foundations. This is just a small list of where you can search for grants, and then we can move on. What do you need to consider with grants? Data, 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 data. Data is so important. And here's what I'm going to tell you. I know that some of you may be on small staffs. Every year, update your grant templates. Make sure that you are updating your data. Make sure that it's not the same thing you wrote last year. And What's also important is going back, we don't have to go back to that donor cycle, but make sure you're stewarding your foundation donors. If they give you a grant, make sure you let them know, maybe on a quarterly basis, the impact of what their gift has done for your organization. Have a relationship, talk to the executive director, invite them for site visits, share success stories, share important initiatives. If you have somebody that, for example, Kasha had a health fair and we had NBC4 from Washington here, share that with your foundations. Make sure you tailor your proposals to align with the funder priorities and mission statements. And make sure that you're providing them all of the detail they need. And a lot of funders want to make sure that your funding is sustainable. Also, build partnerships. You can collaborate with universities. You can have interns that help you with grant writing. Yes, of course, we still have to supervise those interns, but they can really help you. Sometimes there are nonprofit classes and graduate programs that perhaps they can help you with applying for a grant. And then also build relationships with your local health systems because they may know of foundations and funders that can help support you. I'm going to say one thing that's so important here. Please do not discount and run away from AI. I have to tell you that for nonprofits that are not using AI, get caught up now so you're not left behind. AI has changed my life. I use it all day long. I actually pay for ChatGPT, and we're looking at a nonprofit AI tool called Boodle. Please use it, but also recognize that it makes mistakes. But that can help you refresh what you're writing every year. It can help you look for different ways to tell your stories. So just use AI. I know this was so fast, it was scratch the surface. Kasha, do you have anything to add?
I think I would just add in regards to the outcomes and the data. But I know everyone wants to see numbers, but the personal stories that you are able to tell of the people that you help probably are the biggest, they have the biggest impact on people's hearts and make the biggest difference in how much you end up getting.
And I will say that, they do ask for qualitative data oftentimes in grants. And if they don't, and you're working with a grant proposal that has word limits in every single section, look to see if they have anything else you want to share, or they have a place where you can upload something, because it's really important. Kasha's right. We pretty much drive Kasha crazy on a monthly basis asking for data and qualitative information for these grant proposals, but they are so necessary.
Great,
Caitlin,
thank
do
you,
you want
Liz.
me to go to the questions, or are you going to throw them out at us?
Sure, I can throw out the first one in there. Well, there's one that's an easy one, a softball here. If you could repeat the name of the AI system that you referenced.
It's called Boodle Box. Boodle box. That's all one word, Boodle Box. It says
and
for
then,
education, but they presented at a nonprofit conference I went to.
fantastic. And then another question that was in the chat was just, what is your annual private philanthropy budget?
Sure. Our federal contracts and grants, we have a total budget of 8 million. Our federal contracts and grants get us to about a little under 6 million. And so therefore my fundraising budget for this year is 2.45 million. With individuals being the largest piece of that pie. Seconded by foundations, then corporations. I do want to mention, because somebody asked about Boodlebox, I'm going to share another tip with all of you. If you haven't started doing this, there is a podcast called Nonprofit AI, Fundraising AI. I am so sorry. I'm going to get the link and put it in the chat. It is mind-blowing to listen to these gentlemen talk on their podcast about the tools that are out there, and it extends beyond just working in a nonprofit. If you're working for any type of agency, I really encourage you to listen to this podcast. There are so many incredible tools and tips. Obviously, we have to consider ethical AI, and we have to make sure that what we're doing, we're not necessarily putting data and numbers into tools, and names, but it's really important that you're using this tool. I just saw a question in there. I'm sorry. Do you want me to?
Yeah, go ahead. I'll read the question just in case folks can't see the chat, but we're a mid-sized nonprofit, 5.5 million with no dedicated development staff. If you could only hire one position of all the roles on your development team, which would you prioritize hiring first?
Well, I'm going to ask a question back to that person. That somebody asked me where the majority of or I shared that the majority of our funding comes from individuals. Where does the majority of your funding come from?
Well, post-COVID, it has shifted to governmental contracts, but it's between 60 and 70% governmental, 30 and 40% individual. But before that, it was the opposite.
Okay, and then can I just ask, do you already have a grant writer on staff?
We contract right now, but that's one of the positions that we're considering.
Well,
But right now we
so
contract out and we do it with them.
could you keep that position and still ask the same question of me? Are you able to keep that position and still hire someone else?
Yes, I believe so.
Okay, then I would hire a director of development. And what I would encourage you to do is hire someone who is mid-career. It's great to have somebody who has years and years of expertise. The issue is if they've had years and years of expertise, they haven't been a practitioner for some time. And you're going to need to have somebody who's responsible for gift processing, thank you letters, that whole donor cycle. So find someone who is scrappy and wants to really help you build out your philanthropy department. And that's what I would do. And Meg, my contact information will be at the end of the presentation, and you can reach to me too.
Awesome. Thank you so much. That was very helpful.
Great. We started a couple minutes late on this conversation, so I'm going to get to our last question here from Todd is how do you acquire the majority of your individual donors? Digital ads, mailers, otherwise?
Oh, so we started as a grassroots organization in 1992. We have donors that have been with us for 30 years, to be perfectly honest, but those folks are definitely starting to transition out. So now we're looking at them for other types of giving, like planned giving. But it is truly it is a challenge to build an individual donor plan. I think the key is ensuring that you are actively using your board and your volunteers to bring prospects and bring names forward. If you are small, that is key. If you have a larger budget, you can certainly work with a marketing company to buy lists. But that could be hit or miss too. I don't know that I answered the question the way you would want, but you really need a development plan, and you need to build out you need to look at who your current donors are. You need to make sure that you've engaged all of them, that you've brought, I realized some jargon on a slide, Libunts and Sybunts. Libunts are people who donated last year, but unfortunately not this year. Sybunts are people who donated some years, but not this year. Look at your Libunts, figure out, and the Sybunts, how to get them back, your lapsed donors.
Great, thank you. And we'll do our last question with Ashley, and then we're going to move into our next section here. Ashley, I see your hand.
Yeah, I'm just curious. I think a lot of what we're seeing right now is the need to educate donors on realistic expectations on, what return on investment is. So I'm just curious how you guys have gone about that, where there's unrealistic expectations within their, what they're donating or how they're donating. And I think we're trying to educate people to be more open to what the community needs versus what their expectations are. And I'm just wondering if you've gone through some of that education with either current or future donors.
Ashley, I have to be honest. I'm on bad Wi-Fi. I heard most of your question. What I think you asked me is you might have donors who are expecting something unrealistic from you, whether that's in the way of outcomes, or were you thinking recognition? Can you tell me, is that where your head was?
Just in general, is this better?
Yes.
Sorry. I think just in general, recognizing that there's unrealistic expectations when people donate to organizations or to projects, and just wondering if you guys have spent time to educate donors on what it really means and what they're contributing to versus what they're expecting.
Sure. I mean, the one thing I will share, and again, I hope I'm answering your question, is the Association for Fundraising Professionals has a lot of great documentation on what nonprofits can say to their donors about what they can expect. Of course, there's also a donor bill of rights. But I think you just have to have honest conversations with your donors. I don't hesitate to back down when or challenge a donor in a very kind and gracious way if they're asking me for information that I can't share with them. You know, for example, we have to be very respectful of our various rules and around HIPAA and other compliance, you know, matters. And so you just have to really be upfront about what you can tell your donors, what you can share with them, and what they can expect. I don't know that that helped.
No, thank you.
Great. Well, thank you so much, Liz and Kasha, for sharing your insights and tips of the trade. I just want to note, Liz put a couple of things in the chat there. In addition to that, we have a couple of resources to recommend to look for potential donors and funders as well, in addition to the ones that Liz had in her slides. And just like any of the other slides, these slides will be available after today's conversation. So thank you again, Liz and Kasha. Really appreciate you taking the time to share your knowledge and expertise with us this afternoon.
Great. And I threw my email in, and if anybody wants to reach out, maybe we can set up a quick Zoom and chat more about ideas.
Great. Thank you so much, Liz.
Yep. Thank you, everybody.
Thank you.
Great. All right. So we are going to move into the next section of our conversations today. So we are going to move into simultaneous breakout. So you will have the option to enter group 1, which will be focused on a conversation of health center funding with, again, a few experts in the field, or entering group 2, which is going to be centered around HUD funding. This was the part yesterday that I was stressing because I was like, oh my gosh, all of this has changed and nobody's going to know what to say. So we're going to give a lot of grace to our facilitators who are going to talk about what they have been able to use, and maybe we'll generate some conversation about what we all can do in solidarity in the future this way. So with that, I'm going to open up our breakout group rooms. It's going to work the same as the other previous rooms, is that you should be able to self-select which room you would like to go into, either group 1 or group 2. So I'm gonna hopefully make that work. And again, similarly, if it didn't automatically pop up for you, you can click the 3 little dots down at the bottom, or look for more, or another little box that came up with that. I think we're still filing back in just a little bit. We might be about there from our breakout rooms. But just like with our other conversations today, there are a few related publications and resources that can support learning a little bit more about either the HUD funding or the HCH funding opportunities. And certainly that's something from an advocacy perspective, we're going to continue to monitor and share information out as we have it available, knowing that, you know, certain things will change over the next couple of hours, days, years. Well, we'll see. I'm getting Julia's eye twitch, but so our facilitators have also kindly shared their contact information that if you have specific questions, feel free to reach out. These are part of the slides that will get posted. So we are entering the last part of our day and conversation here. So we've talked about 5 different major funding sources, and those are not even all of the different ways you all fund your programs, but we are going to bring together a program panel of folks who are going to share how they make this work, what they make this look like for their organizations. A couple of familiar folks you've heard from, but we'll be able to draw all of the different pieces together of their organizations. And so really happy to have Laurel, Richard, and Dorothy all here to be able to share with us today. So Lori, I'm going to go ahead and turn it over to you. You are up first.
All right, can you hear me? I was on Teams and Zoom at the same time just now for funding, fun. You know, some of you heard a little bit about my organization. So in Cincinnati, Ohio, 20 beds, we serve male and female adults. we're a standalone and we're considered integrated, or we identify as integrated clinical care model. I let people know that our funding kind of falls into three general buckets. The first being healthcare organizations. So that not only includes hospitals, but a little bit of funding that we receive from our FQHC, one of them here in Cincinnati, and a little bit of funding that is specific to individuals with HIV or AIDS. And then we have another third would be in state and local funding. So we have, and it just kind of sheds light on the fact that we apply for absolutely everything we possibly can find that is a fit. It's a lot of work, but we do it and we make it happen. So we have Hamilton County tax levy funding. We're in the senior services levy, so that funding applies to our clients who are over the age of 60. That has not been a problem. We were nervous. We thought it would be a problem, but it is, our population is aging. So we typically bill that fund out. And then City of Cincinnati and State of Ohio through Human Services or Department of Development. And then the final third, which I feel like we have too high of a reliance on, is private grants and donations and fundraising. One of the things we're seeing that it's a little concerning, but I feel like we have a way to make it happen, is that we're seeing more and more grantors, even at state and local and private, are looking for collaborations. What's scary about this is right now, I don't need to add additions to our program like art therapy or music therapy. I don't need funding to do that right now. I need operating funding. So the collaboration piece is a little bit challenging. It's us trying to find the right collaborator. It's happening more and more. So heads up to anybody going for any of these funding sources, prepare to collaborate. And then of course, we rely on community specific outcomes because they are really the most impactful when we're reporting out our outcomes and we're showing how we're impacting our local community in a positive way. And then showcasing services, we really focus on and highlight educating our clients. That seems to be the most impactful for us in seeking funding, because that seems to be a benefit to everyone. So it's helping EDs have less recidivism, less experience, and for our MCO partnerships, that they're seeing their members utilize their benefits more effectively. Okay.
Great. Thank you so much, Larry. And I just want to note for folks that everybody's going to present, and then we're going to have time for discussion and Q&A. So if you have questions for our presenters as they're talking, please put them in the chat and I will monitor that and we will dive into them all together. But with that, I'm going to invite Richard to come on and share a little bit about the Boulevard and how they weave together their funding.
Great, thanks, Caitlin. And for those that weren't in the last breakout session, again, my name is Richard Ducotton-Saylor. I serve as the CEO at the Boulevard of Chicago. The Boulevard, which is our medical respite care program, is a 64-bed medical respite care program. We're located in the Humboldt Park community on the west side of Chicago. We are a shelter-based program. We work in conjunction with a partner that provides the clinical health care services on site. We partner with PCC Community Wellness Center, and we identify as well as an integrated clinical care model provider. So similar to what was presented before, we like to kind of lump our funding sources into what we consider to be 4 different buckets or sources. Number one, we receive funding from the government, from public sources. So we receive funding from federal government. Part of that is composed of the U.S. Department of Housing and Urban Development, as well as the the VA, which is the Veteran Administration. as well as local funding here in Chicago. So through the Chicago Department of Family and Support Services, along with the Department of Public Health. The other sources that compose our funding are considered private funding, again, private philanthropy, which composes about 18% of our funding. We have also kind of seen a shift as well as far as a concentration on providing support for very specific type of services or around specific issue areas. So we've definitely seen a shift over the last several years from a movement away from providing general operating support, to supporting more specific type of issue areas. I failed to mention that the government composes about 48% of our budget. The private philanthropy is about 18%. And then about 20% of our funding is composed from hospital partners as well as managed care organizations. And then the remaining bucket is composed of congregations, corporations, as well as individuals and special events. And that's about 14% of our total budget for our medical respite care program. As you can imagine, all these fundings streams have to be kind of woven in very carefully together. We want to make sure that we are fully supporting all of the costs associated with operating the medical respite care program. These costs are kind of divided up into different type of categories or line items, such as services, operation, administration, as well as indirect costs. We've recently been certified as a behavioral health clinic, so we will be able to bill under Medicaid, hopefully in the very near future, for certain type of case management as well as supportive services. And of course, as many here are looking forward, and here in Illinois, the 1115 waiver was passed, and it's still in the midst of being further developed as far as identifying rates and eligible reimbursable services. So we are looking forward to being able to hopefully bill under the 1115 waiver within the next year or so. Our development team as well is constantly working on prospecting new private opportunities. I think it's just a never-ending process as far as being able to identify funding sources that are in alignment with what you're trying to accomplish with the medical respite care program, as well as trying to understand what your funding gaps are and how you could potentially meet those with private funding. And then lastly, I just wanted to highlight that we have also worked with consultants to kind of help manage our managed care organization contracts and relationships with our hospital systems, and that it really is a very collaborative approach. So you have to make sure that you're really building that relationship and understanding their needs and how you could work together. And so it does require having to kind of renegotiate from time to time and look at your contracts and making sure that they are of benefit to both parties. So that's all I have for right now. Thank you.
Great. Thank you so much, Richard. And last, but certainly not least, Dorothy. Oh, Dorothy, you're on mute still.
Thank you. Sorry about that. I'm Dorothy Slama with the Sulzbacher Center. We're in Jacksonville, Florida. I'm the nurse administrator here. We're a 15-bed respite program. We have both an FQHC and a shelter on campus along with our respite program, and we're a comprehensive clinical care model. So like others in our group, we do weave together quite a few different funding sources. Hospitals and referring agencies are our primary funding sources. We have contracted beds with local hospitals, and we have recently expanded the referring agencies that we're accepting patients from a little bit by accepting folks who are in hospice care that aren't yet ready for inpatient hospice, and working with some cancer therapy groups. So folks that need chemo or proton therapy. And of course, they can't really successfully receive that treatment if they're still on the street. So some of those programs have grants of their own, and we've been able to work with them to fund the beds. For the healthcare and behavioral healthcare, and for medications, we use the FQHC, the 340B medication room, and we're able to use private insurance, managed care, Medicare, HRSA funding for those aspects. A lot of our case management is funded through state and federal grants. LSF is the agency that the state uses, and they have targeted grants for people with specific areas of need that often dovetail with the folks that we're serving. Also for case management specifically, and for some of the housing placement, we're able to use state grants and SOAR. And then we have a lot of supplemental funding that we receive from a variety of sources for specific program areas. So both on the front end through establishing relationships with these programs so that all of our clients might be part of them, or through on the back end, kind of through identifying for each client how their needs might dovetail with other programs. We can enroll them in other programs that already have sources of funding, which increases the range of services that our clients can receive and reduces our cost in making sure that those services are provided. So I would echo the ideas that Laurel and Richard were talking about around the importance of the collaborations with other agencies and the development and measurement of deliverables. The more data that we're able to collect, and even though some of that does vary from funder to funder, there are some core deliverables I think we've heard over and over again today that most funders really want to see, and having that data ready really helps with the process. So around developing the funding, sustaining the hospital collaborations for us is a big piece of the puzzle. They're a big source of funding relative to our respite program, but a very small part of the hospital's budget. So we want to make sure we remain relevant. Our MOAs do include written deliverables. We give them a quarterly dashboard, making sure that it has those deliverables that are most important to them, the 30-day readmissions, the percent of clients that are stably housed upon completion of the program, and then referral acceptance rates and other variables that they might find important. Make sure that we're having in-person meetings, not only with the funder, but also with the individuals who write the referrals, like the case managers at the hospitals. And we set up tours so that the case managers from the hospital can come and see the program firsthand, see what's happening with the clients, and be better able to describe it to people they're getting ready to refer to. Again, increase the number of good referrals that we get from them, that we can really get people engaged in the program and best serve the hospitals. And then we're very open to providing informal assistance to the case managers at the hospital. So they have a lot of folks they're not sure where to place, who may not be appropriate for medical respite. But if they call us, either myself or one of my case managers will work actively with their case managers to try and connect them with some of our collaborative partners or other sources of support in the community. So they see us as a resource and not just the respite program. So when we're working to develop additional lines of funding, again, back to the collaborations being so important. So we have regular, both informal and structured meetings with other agencies in the community so that we can identify some recurring needs that maybe together we can meet better, so that if there are opportunities for funding that we wouldn't be able to pursue on our own, but maybe with the collaboration of another agency we have better opportunity to do so. Participating in the local HMIS really helps to coordinate services and helps us to ensure, again, that we're using our funding effectively and connecting our clients when we can to other providers that already have services set up and funded. As we come across new unmet needs, that's when we have a good opportunity for funding. So if we're hearing from the city or it's in the news, we're talking with other nonprofits around us about how could we meet this need if we all came together. And when we have those ideas already at least partially hashed out and then approach the funders, it helps us to move forward much more effectively. And I know that keeps coming back up, but the more agencies that are involved, the stronger those cases will be. We've had a lot of funding recently around substance use. So that's a huge need with our population. So we begin at intake with connecting folks to those services, especially the ones we're already providing in our agency internally. At assessment, we'll connect them with those. But then as we work with clients, find out more about them and learn more about their needs and their response to the services we've already connected them with, we have more opportunities to connect them to other services. So if what we have is not going to work, we can still work to connect them with another agency that might have a different funding source and a different program model. So talking about how we make sure that we continue those connections becomes important. So when we're doing the case management meetings, they're actually in our EHR so that the clinical providers can see what's going on in the social connections as well. And all of the different providers can collaborate together to connect people to resources.
Great. Thank you so much, Dorothy, Lori, and Richard. And I'm going to stop sharing and invite folks to put your questions that you might have in the chat for our panelist presenters here. But I'm going to start out with one just to kind of get the conversation started here. And I'm curious, in terms of all of these different funding opportunities that you could have or present themselves, how do you figure out what's going to be worth your time? Because all of these take effort, right? So how do you kind of weigh that out and determine this is worth pursuing for our program?
The first thing for us at Sulzbacher is we look at what are things that we're already doing and already successful at. So if it's a program area where we've already had some success and we're just going to need to maybe change the reporting structure or add some additional staffing, that's something that we're going to look into pretty quickly. If it's something that we've never done before, our staff team doesn't have the expertise, that's going to be much lower on the list. So we're going to first look at playing to our strengths and using the skills and talents and systems that we already have successfully demonstrated before we pursue other funding sources.
We kind of had to go back to the drawing board. When I first started with our organization, we were customizing every funder, every funding agreement to what they wanted. And it was chaos. So we sort of drew everything back in, and our goal was to build a platform of data points that we thought could really encompass pretty much anything anybody was asking and prioritizing those. So, I go back to what was most important for our community, what the community priorities that showed up in all the community benefit plans for the hospitals, and just maybe what the health department, we reached out to a bunch of sources to try to see what is most important, and then set up this foundation of data points that we could suggest to those funders when they were asking for what goals will you have during this grant period and what do you hope to achieve. And typically we had enough to choose from that it would satisfy them. You always have those that pull crazy ones out though, and I've had enough funders want to know what happens to someone that is discharged from our program in year 1 or in year 2 post discharge. And, we never had access to that information. So because it was so frequently requested and something we didn't have, we ended up adding an extension to our program that allows us to stay with those discharge clients, not all of them, but most of them, up to 6 months to a year after discharge. And so it's giving us that data set that's rare, that we really want to focus on the data sets we have and utilizing those for goals and outcomes for grants, and how we determine. So if it is really out of line with what we're already doing, we'll probably respectfully decline to apply or accept. I'll give you an example. We had a group of volunteers who were, they gave a really nice monetary gift, but they expected to come in and do something. And it just wasn't going to fit with the program, what they were choosing. And so we had to have that difficult conversation saying, what you want us to do for this money that you're giving us is kind of disruptive and really out of line with mission, out of line with programming, and we need to consider something else. So you have to weigh that piece, but also how much work is something going to take for the money that you're getting. And that is another consideration, because as much as I love to be someone mentoring young future philanthropists, participating in those processes with a lean staff isn't always the best use of our time. So we've turned down those opportunities as well.
And I'll just add a few things to that. Just echo everything that both said. I think just kind of want to stress the importance of having an effective, and well kind of thought out fundraising plan or development plan that will really help kind of guide your decision-making process throughout the rest of the year, as far as understanding what your funding gaps are, what your priorities are, and where you will be targeting, your prospect research. We do know from time to time there are, certain grant opportunities that kind of pop up. And so, but if you could just refer back to that funding plan and priorities, and if you did a needs assessment, it would require relatively low effort as far as really understanding if this would benefit or really provide any type of return, that you would be expecting, versus the lift that's required. And just I did see a question in the chat box as far as how the Boulevard decided to partner with which hospitals. So many of the hospitals we've been working with, we've have established relationships for some time, but they continue to evolve. We've obviously continued to have some strong relationships by, whether including, members on our board that are affiliated with the hospitals. But, as I think Dorothy mentioned as well, like, it's not only about being viewed as a referring organization, but, it's being viewed as a community partner and being able to, assist them, even though you can't necessarily always, accept clients that may not be appropriate or eligible. But another thing we took into consideration is proximity. We definitely want to work with the hospital that is of closest proximity to our facility, in which those are generally the hospital where, our clients will be taken to should there be an emergency or have appointments. So making sure that we have a very close relationship, with the closest hospital system. And of course, just where we would receive general referrals from as well. So we're starting to recognize that majority of our referrals are coming from one specific hospital. We'll then kind of schedule some additional conversations to see, how can we formalize some of those, this relationship or partnership.
Great, thank you all. And I do, Meg posted a question in the chat, which I think will be really interesting to hear. If any of you all have diversified into formalized relationships with behavioral health hospital placements. I don't know if anyone on this panel has done that yet, but that is something I know programs have thought about.
So we have pretty strong relationships with a couple of providers, but typically it's us referring a client to them. So not the opposite. We just don't have the capability. And I don't think we would ever alter our program to specifically cater to that. And I know a lot of you, I mentioned this earlier, we're licensed and that would be prohibitive to our license. So when we do encounter a client that is beyond our capabilities to care appropriately for, we are reaching out to some of our behavioral health partners to see if we can get a bed.
Can you say just like a tiny bit more about why it's prohibitive to your license?
So it would be on a case-by-case basis, but most likely if it requires any sort of medication management of behavioral health issues or physical restraint or locked facility, none of those are permitted in an assisted living facility. So to not have to draw that line, we can handle a certain amount of behavioral health issues, but once they hit a certain level, then it's beyond our level of care. And I don't think we would alter at this point, we wouldn't alter anything from that.
Thanks, Lori. And just to provide a little additional context for those who weren't in the conversation with Lori earlier, my understanding is the state of Ohio requires you to be licensed as an assisted living facility. I just want to note for other folks panicking in the conversation, that's unique to her state, that the majority of programs do not have that level of licensure. But that is one of those important features of understanding sort of the state and community regulations and how that might apply to you. So just to give a little context there.
I just wanted to say, we have had people in our facility, which is a medical respite for unhoused families with minor children that are in a medical crisis. But there's always that layering of issues and a lot of times mental health issues. I stepped in as interim manager for 3 months and I could see, I mean, we finally got something in place with a social worker and a nurse and the manager to determine if we were capable of meeting the needs of people. They didn't have anywhere else to go, but if we didn't have the capability, if their mental health issues were beyond our capacity, we weren't doing them anybody any favors by taking that on, because we had other, people we were responsible for in the house and them. So I could see where, that's a whole other level of care.
We haven't accepted folks directly from inpatient mental health yet, but we do have some collaborations, a mental health offenders program where judges will defer clients to us rather than keeping them in jail. And then we have a group of staff members specific to that program. So they may be in medical respite with that extra layer of support to provide some of that extra medication management. And then we have the psychiatrists on staff who will help us to determine people who may be able to function at a level that is acceptable within the respite program and still move forward with the care that they need. But it is a tough balance to decide who's going to be successful in our program and whether we have the depth and breadth of care that they need to remain successful.
And I will just plug in the chat, we do have a series of online courses focused on supporting people with behavioral health needs in medical respite care specifically. It's a 4-course series, so lots to learn in there. But that, you bring up an important and thoughtful point, Meg, around, thinking about these different funding streams and where we might be able to pull that in. And, behavioral health may be a place to be able to weave in some opportunities, in certain dollars, but making sure that your program is equipped to be able to support folks across the spectrum, of course, is really important. So
question for you, with when you're adding all these in the chat, are we gonna get those in the material?
Yes, yep, ideally everything that's been linked today will get posted in a follow-up there. So
awesome, thanks so much.
Yeah, so we are just about at the end of our time. So I just want to open it up to Lori, Dorothy, or Richard, if you have any final words of wisdom based on your experiences or just, thoughts for programs and figuring out how to put all of these things together.
Yeah, I mean, I would just say, just think creatively. Don't, instead of seeing something as a barrier, see it as an opportunity. I know, sometimes you have to think outside the box, specifically when funding is limited. So I think just really evaluate your opportunities to see how, they could be of potential benefit, to your clients. And don't be afraid to kind of move things around. And as far as I think just think outside the box, and don't be afraid to kind of approach donors and have very candid conversations with them.
I would add that I was concerned that the material that I was going to present would make it seem like it's something easy, and it's not. It's not easy. It can suck a lot. I hope I can say suck in this and it's recorded. But you just gotta be able to shift gears quickly and think of it in different terms, and not give up. And that is the one advice I give everyone. You've got to be the squeaky wheel when you're trying to get your hospitals to respond and to give you the attention. You just can't give up, and you can't expect them to come to you. So we maybe made it sound like it's easy. It's not easy, but it's worth it. And every time you get something, you get the stamp, you get the multi-year agreement, you get the nice fat check, is one step forward to more sustainability. And, that's what I have to keep in mind when I tell my staff how much I hate having to ask and ask and ask, but you get better at it all the time.
Wonderful. Thank you, everybody. I did just launch a poll. Your feedback is super important to us in terms of figuring out where we go next with these conversations. I think every conversation we had today, we could have had and spent a lot more time. So please take a moment, fill out the poll just so that we know, kind of how we did today and what you need. I will also just kind of blast that this is one of many events we have coming up. Today was focused on funding, which, fun or not, how much you like that. But we do have a few other important conversations coming up. If you want to do some quick clicking right now to open those links, we have our February 26th all-member meeting. I mentioned in that Barbara will be joining us to share policy updates, which will be certainly interesting in a month's time to see where we are with all of that. We also have role meetups for specific roles within your medical respite program for you all to come and talk in community together, much more informally, no PowerPoints at that particular session. If you're interested in becoming more involved, our RCPN steering committee is open for nominations currently. And we also have our awards open to honor somebody involved in your medical respite care program. So lots of opportunities to stay in touch with us. Usually the recordings and materials are usually posted within a week. So please check back on the website. We'll also try to get an email out with everything with a few updates in there. With that, I just want to say a huge thank you to everybody who presented today. This would not be possible without the many, many brains that offered to share their experience with us this afternoon. Thank you to our attendees for being part of this. It was not a short day, but I think a really important day. So with that, I will see you all hopefully very soon. And thank you again, everybody.
Thanks, everyone.